Our topic today is community-based suicide and overdose prevention, avoiding unnecessary hospitalization and incarceration. And we recognize the sensitivity. Session one, we talked about, and just a quick review, we looked at building collaboration around COVID-19, natural disaster impacts and mental health crisis care needs and assessments. That was in October 2021. And then our second conversation together was around crisis continuum of care of resources available for faith leaders, lay ministers, and faith-based behavioral health resources available. And that was in January. And so again, today's conversation is around collaborating as it relates to faith-based initiatives around suicide prevention and overdose, how to avoid hospitalization and incarceration. So we're very grateful to have you all joining us today on this conversation. We can go forward. So our learning objectives for a day, and I'm not going to read the whole thing to you. I just want to jump right into our learning objectives for a day. One, we're going to look at just some data around to set context around what we're talking about today, but also learn about guidance for behavioral health staff to include faith-based or faith in behavioral health and crisis care assessments, and then to consider places to codify and improve existing crisis response protocol in faith communities. So that's our overall objective today. And then we also have we know that a lot more will come out of this robust conversation. And then you'll be given a little homework at the end, which has been pretty consistent with our last two sessions. But what we're really hoping to look at is to discussing how faith leaders, as opposed to calling 911, what we can do to be a part of the process of healing, and like calling 911 and mobile crisis units, as opposed to always going right to 988, as opposed to going right to calling 911. And then our next session will be in June, and we're going to be talking about faith, community, and behavioral health departments, collaboration, cross-funding. So you don't want to miss the next session in June, because we're going to be talking about how do we fund all of this wonderful stuff that we've been talking about in the last three sessions. How do we secure funding and collaborate on future goals, as well as impact that we want to make as faith communities, but also behavioral health communities working with faith communities? How can we collaborate on some funding? So that'll be the session in June, and we really do hope that everyone will join us there as well. So again, I'm Reverend Najuma Smith Pollard, and I am the Assistant Director for Public and Community Engagement here in at the USC Center for Religion and Civic Culture and the Cecil Murray Center. It's a very long title. Don't try to remember it. Everybody calls me Reverend Najuma, so feel free to do that. And if you want to follow me on any of the social medias, my social media handle is Rev Juju, at Rev Juju, the at symbol Rev Juju. It's really simple. And if you put that in any Google search engine, you will find me on all the socials using that simple Rev Juju. But I'm also a pastor. I pastor Word of Encouragement Church here in Los Angeles, and I've been in ministry now 25 years, full-time ministry. And a lot of what we've been sharing in the last two sessions and today are things that, and were efforts that we have, that I've participated in as a pastor, but also as a community leader here in Los Angeles. And so grateful to talk with both faith leaders, whatever capacity that you serve in at your congregation, but also those of you that work in the behavioral health science field. All right, next, please. So our big idea in this 4-part series, and I show this slide each time because I really want us to understand the big idea and the goal of bringing both behavioral health and faith communities together, is that we recognize how faith communities are embedded assets. They are embedded assets. We are embedded assets in the community. So all of our faith leaders, pastors, members of congregations, clergy, whatever your station, your role is within your faith community. I hope you see yourself as an embedded asset, but we also want to encourage those of you that work for agencies and institutions around behavioral health, mental health, substance abuse, and things of that nature to understand that faith communities and community members who are parts of faith communities are embedded assets. And we are part of the efficacy in reaching the community and working with faith communities. So even my role here at USC, we are often approached by larger organizations as well as corporate entities. How do we get to the community? Because faith communities are embedded assets. So that's been the big idea over the last two sessions, today's session and the one coming up in June. So we want to see the cross value of working with faith communities and where faith communities can help and be of assistance to this broader work of making sure that all community members and residents are getting the resources and services they need by building that bridge between behavioral health and faith communities. For far too long, we've kind of lived as separate entities, but part of this collaborative effort is to bring these communities together and build a bridge. And we'll look at that in today's slide, in today's presentation, the bridge that we're really hoping to build around all of these topics. Next, please. So our goal today, we're going to look at a couple of community-based strategies that have helped to stabilize health crises in the community and avoid emergency rooms, psychiatric hospitals, jails, prisons, like resources like 988 and mobile units, as opposed to calling 911. We've been conditioned in our communities to just run to 911, but we have seen that that may not always be the most effective response in all cases. And so we want to be empowered to know that there are other ways that we can be a part of bringing healing and hope to our communities. And then our second goal, behavioral health, as behavioral leaders, will learn how to include faith communities in their behavioral health and crisis care assessments and work that you all do. So those are our goals for today. So let's really get into that. And also, as you all come on in, we want to encourage you to continue to include your name and what organization or church you're representing today. We'd love to know who's with us. So as you come in, we know some people have just joined in. Please put your name and your organization or your church or both in the chat. So let's go to the next slide, please. So our conversation is going to be broken up today into 3 parts. And also, if you have thoughts and questions along the way, we do have a few people from the team that are watching the chat. So if you have thoughts and questions along the way, feel free to put in the chat any questions or thoughts that we can illuminate and have part of the conversation. We do want this to be interactive. We know everyone can't talk at the same time, but we certainly want to receive your thoughts, comments, questions as we go along the presentation and include that in the conversation today. So we'll look at 3 kind of buckets today: community-based strategies that are working. Why do we look at alternatives to 9/11 and places of faith and healing, what that looks like. And then we're also going to look at some barriers to this work being done that we think are important. And then later, you all will break off in pair share and have about 10 minutes to discuss some of what we've shared today, and also what you may have to share with each other as we go forward. So let's talk about community strategies that work. So I want to lift up a couple of things that I've seen work, and then feel free again to share in the chat. So one organization that I know does something called Hope Forums. And so the idea behind community-based strategies is to really look at the issue of mental health, addiction, suicide from a holistic standpoint. And when faith communities get engaged in this work, because our faith challenges us to look at the whole person and not just at the symptom and the problem. When we look at community-based strategies at play, the goal, of course, is to have a holistic approach, right? And so Hope Forums, and you can, I don't have there, I was looking for there, they don't have, and I'm assuming for safety purposes, they don't have their information listed publicly. So I will have to send that to you, Angela, so we can disseminate to the group. But these Hope Forums were an opportunity where people were brought together in very small groups. And then they would have conversations, very forward conversations around suicide, suicide ideation, addiction, mental health challenges, but they were Hope Forums. And the whole idea is to incorporate the conversation around a person's faith, where they are in their faith journey as well, and to look at the challenges that they're facing. And one of the things that they saw in these Hope Forums, so people were brought together in large groups and then broken off into smaller groups, is that they found in these small conversations, by having a very forward conversation, a very honest conversation, people were able to share what they have experienced, but also share what they hope, if you will, to walk away from. These were not necessarily people who were in the moment experiencing, a suicide ideation or things like, but they were talking about these issues in a very forward way, in essence, to help communities look at the issue, not so much from a judgmental standpoint, but from a very honest, open, let's talk through it. And because what we have discovered is that in talking through some of these issues, what it does is it prepares people, it informs people to make different decisions. So Hope Forums, and what they found in doing the Hope Forums is that when an issue like drug use, overdosing, where someone's life was lost, or where there was suicide, that individuals, their response, they knew that they could come to that space because the Hope Forums were established there. And so what they saw is that when these issues would come up for people, when things would happen, those who had participated in the Hope Forums knew that they could come to this congregation and really receive the resource that they needed to get the help that they needed going forward. This is a great way to allow for prevention and even postvention. And postvention are the things that we do after someone has committed suicide, and hosting conversation as well as healing opportunities for those impacted by that. And we'll talk a little bit more about that in a moment. But these Hope Forums were very, very helpful in giving people an identified space where they could come to talk through the issues, but also in the event of a challenge, they could come and they knew where to go to. Oftentimes what we have found is that when things happen in community, sometimes people don't know where to go to. So these Hope Forums gave individuals who have been in these conversations a go-to place. In some I can't remember who said it, but in a book that I was reading, they talked about third place, right? And so having this place, where an identified place that people could come to. The second community-based strategy, so that's one. The second community-based strategy that we saw worked is a church in not Westminster, I'm going to say it wrong, where they would have suicide prevention community events, community awareness events. And so this was an opportunity. The church was hosting these suicide prevention community events where they would have the community come out, all the local congregations, as well as practitioners, to come out together and share in an open space. There was opportunity for dialogue, opportunity for sharing, an opportunity for being in connection and fellowship with others. What we have seen to be part of this holistic approach is connection. Again, we want to offer space where people can know, where they have an identifiable space, as well as those who are leading in the efforts for suicide prevention and postvention, who are leading in these efforts, so people know where to come to. And so they would have these community events, and the community events would connect people, because part of what we know is necessary in prevention is connection. And faith communities offer and can create this connection for residents within their neighborhood, as well as for behavioral health specialists to connect with community. And so the Hope Forums offered a way of connection, but also a way by instilling the conversation around hope, and also giving people an identified place. The community events created a deeper sense of connection and offer connection, where people could get connected not only to congregations that were in their area where they could get connected for resources and services, but also just for spiritual growth and development and spiritual connection, but also being connected with specialists in the area that they were living in or residing in at the time. So that's a second model, if you will, or community-based strategy that we found to work, where these very outdoor, very public events that brought people together and then created connection. The third strategy that we've seen work was embedding. So I come out of the AME Church, and one of the things that the AME Church did as a denomination was embed in their discipline safe communities, within the discipline of the AME Church. What it established by doing that is that every congregation was then designated safe space for people to come, to share, to get assistance, to get resources. And what we have found is that when denominations embed within their discipline or within their bylaws, that's what I was thinking about, or within their policy, that we are a safe community. We are a place where people can come to, where we will find resources, we will find connection, we will make sure that individuals are being serviced in the way they need to. And so a third strategy is embedding within the policy of the faith community, within the policy of the congregation, within the policy of the denomination even, that this is a safe community. And so, and we saw that strategy be very helpful, and then making it very public that all of our congregations would be deemed a part of a safe community, a place where people can find safety. Again, what we know is that when people don't have connection and they don't feel they're in a safe space, they're often less likely to share, to connect, to go there, to find resources and assistance. And so those are three strategies that we've seen work. One, the Hope Forums, bringing people together in smaller conversations. Two, the larger community programming around suicide prevention, and having an open forum where people can connect, but also embedding within the policy of our congregation, our spaces, this safe communities practice, where every church or every congregation or every worship space is a designated safe space. And so those are just three community strategies that we have seen work. Again, we want to invite you to share in the chat. You may have other community-based strategies that work. And the goal around community-based strategies is that we're looking at a holistic approach, right? Connecting both faith communities as well as our behavioral health services together. So the second bucket that we want to talk a little bit about is why alternatives to 911. This is important because when we look at these issues, what we want to move away from is criminalizing mental health, criminalizing addiction, criminalizing grief. And so 911, while it is important to use when needed, we also want to move away from criminalizing people who are having, who are either going through an episode or experiencing a moment in their anxiety or in their addiction. We want to move away from criminalizing by moving away from calling 911 when we can, and providing people with care as opposed to criminalizing them. And oftentimes 911 can lead to people being criminalized for where they are mentally, emotionally, and psychologically. And by way of example, I want to share this example with you. We had a young lady at the time I was pastoring a church that was just off Figueroa. And part of what, for those that live in Los Angeles, in South LA, you know that Figueroa is known for trafficking. And we had a young lady that we were working with. We had a program at the time called Restoring Rahab, where we work with a lot of young ladies who are being trafficked along Figueroa corridor. And they could come to our church because we were a designated safe community, and they could get the care that they needed. And we had a young lady in my office, and she said to me, "Pastor, I don't need to go to jail. I need help. I don't need to go to jail. I need help." And we were able to get her the help that she needed. And so part of why it's important that we work in collaboration and connection with each other, behavioral health organizations, as well as faith communities, is so that way we are building this bridge where we're providing help as opposed to criminalizing and sending people straight to arrest, as opposed to giving them the service and help that they need. And faith communities, our pastors, our clergy, are ideally positioned to be part of this process. We should never take on the role because we're not certified, we're not licensed to do that, but we certainly can be a gateway. I was able to be a gateway for this young lady, connecting with the services that she needed. Clergy, faith communities are also ideal in that we can provide an opportunity for radical acceptance when people are going through an episode or just dealing with their own struggles. Faith communities, by way of our faith, can be a space for radical acceptance. Because one of the things that we've learned is that what people need is to be accepted and loved for where they are, and not necessarily criminalized for having an episode or criminalized for being in behavior where they could use more. I'm sorry, I just dropped something important. Where they could get assistance, where they need assistance more than they need to be criminalized and to be punished. And so this is where faith communities are uniquely positioned to help in this way. And then our last bucket in this portion, then we'll move on talking about barriers. And again, we want to invite, feel free to share in the chat any additional comments that you may have. Places of faith and healing. So what we do know, what is at the core of faith communities is what faith communities offer, which is space for healing, and the message of healing and the hope of healing. And so when we see individuals who have either had experience where someone in the community or in their family has committed suicide, or they've overdosed, or they're going through an episode that leads to one of these tragic outcomes, the church often is not often, but is often seen as a place of healing. And people, even if they're not members or they're not necessarily embedded in that faith community on a regular basis, will often come to faith spaces for the healing, for the postvention, for the where do I go from here? They often will come to congregational spaces to get meaning, to get connection, to find hope again after such tragic events. And so for those looking to work with faith communities, the reason that's an important work is because places of faith, by way of the nature of what we do, are a place of healing where people should be able to come and find healing. And it's also a place where people often go when they're either in their situation or they have experience with the situation and they need to find healing for the grief or the pain that they're experiencing as a result of connection with someone who may have committed suicide and or overdose. And oftentimes these things also happen in faith communities because you may have family members, individuals in the community that are part of a congregational space or worship space, and these things happen. And so what places of faith offer is this direct work around healing and hope and offering that to anyone that comes to the doors. And that's that kind of embedded resource. So for all of our behavioral health workers, what we hope that you walk away with today is seeing how faith communities really are a key to families and individuals healing. And that when we collaborate and work together, not only are people getting services they need, but they're also getting the hope and healing that they need to live forward. And so we continue to build this bridge together. So again, community-based strategies, because they offer this holistic approach. Why alternatives to 911? Because we don't want to criminalize people who are going through something emotional, psychological, and mental as well. We don't want to criminalize that. We want to move away from criminalizing and really getting people their help and services, and not just incarceration and or, this kind of dismissing people. And as I mentioned before, the young lady who said to me, "Pastor, I need help. I don't need to go to jail." And again, there are times when we need to call 911, but when we work together, there are ways that we can create that bridge, that we can avoid criminalizing people who are going through that. Then finally, the last bucket again is faith spaces, clergy, whether that is the imam, the priest, the pastor, et cetera, the lay person. Our faith spaces are places of healing and hope. And people know that and will often come when they're dealing with something, when they are having experience, but also by working with faith communities, we can hold events and have conversations around healing and hope. All right, wonderful, thank you. So those are the three buckets that we want to lift up today, why this work and this collaboration is so important. If we can go to the next slide. So what we want to share a little bit about is barriers. And this is important because a lot of times we want to just move in and work together. But when it comes to this conversation around suicide and death that may be related to an overdose, these are highly sensitive areas, even within the faith community. And so we want to talk about some of the barriers to be aware of as we are building these bridges with our faith communities, just some barriers to be aware of, and then we're going to talk a little bit about how to overcome some of those barriers. So while it is we want to encourage working with faith communities to identify opportunities, here are some barriers to consider that we may have to have some sensitivity toward as we're building this very important bridge. Cultural response, right? There are varying communities, how varying communities look at the issue of suicide and even overdosing that may lead to death. So you have some congregational spaces, some faith communities that really see the issue of suicide as one related to sin or not of God. And again, I'm not here to weigh in on theology or anything. I just want to lift up the cultural barrier, the religious barrier that those who work in behavioral health might come up against when you're trying to connect with a faith community, and how they see suicide. So not to be surprised if you, in trying to work with a faith community, may talk to a leader, a faith leader, a pastor, or someone in the faith community, and they have a very standoffish or really, no, we don't want to engage in that conversation because culturally, religiously, the way they see suicide and the issue may create tension when it comes to working together. So when we look at that, one of the things that can happen when we have a cultural response is to offer conversation or to respond to lead the conversation in a broader dynamic that culturally we understand where your community might be on the issue of suicide. And we want to offer that there are those that may be impacted, and how do we help bring them along in their space of healing. And so again, culturally, there are communities that really see the issue of suicide as something other than needing help, but something that we just simply do not talk about, that is taboo. And so you may run across this, which means the sensitivities in approach may have to shift. How you lead in conversation may have to change. Then we have the reality of denial. I was working with a family, and the mother was just in denial, right? And we see this even within faith communities, where families and communities are often retreat to denial or silence or over spiritualization, and which can be very detrimental when communities need help, hope, and healing, choosing to be in denial by silence and or over spiritualization. So again, these are just a couple of a barrier that you may, if you're trying to work with a faith community or work with a family, is the reality of denial, that some people just retreat emotionally, psychologically, for the purpose of their own ability to live forward. They retreat to denial and or silence. We don't talk about it. And we know that in some cultures, silence is the practice. We don't talk about that. And we hear people say that all the time, that's not something we talk about. Or we don't talk about how this person died or how this person ended their life. We just don't talk about it. So that's a reality, the reality of denial. And a lot of times people retreat to denial because it's their own way of coping. It becomes a coping mechanism. So just something to think about. And then also the faith response. Varying faith communities address the issue of suicide differently in their practice, in their worship, in their religious practice. You have some communities that are very open and honest. Let's talk about it. You have even clergy that will preach. There are texts that deal with suicide. You know, we're coming up on Good Friday. There's Christian texts that lifts up Judas, who committed suicide. And so there's text. And so you have some communities that will use that text and others to really lift up the issue of suicide and prevention and postvention and all these things. And then you have some that see suicide again, and their faith response is very different. And so these are just a few barriers that we have to work to either overcome or be gracious and understand where people are in having this discussion around suicide and mental health. So in the chat, we welcome anyone to share some other barriers. If you know of any other barriers or other barriers that you've experienced, we invite you, I want to invite you to share in the chat other barriers that maybe you've come across in trying to work with communities and or as a faith community leader, or if you're engaged in a faith community, some of the barriers that you have seen. Something else that's not listed here on the slide that I know I've seen is just people not knowing what to say, right? So that's also a huge barrier when you're looking at a faith leader who just doesn't know what to say, which is part of why we're having this conversation and we're connecting with communities like CARE, because sometimes even as a pastor or an imam or a priest, et cetera, they may not have the language, they may not have the experience, and they just don't know where to start. So I didn't have it on my slide, but that's also a very real reality, is people just not knowing what to say, even if they're very faithful people, individuals very much in their sacred text. Some issues people just don't know what to say, and that also can create a barrier when we're trying to do additional prevention and intervention and postvention for families and communities. Next slide, please. And so we want to talk a little bit about postvention. You've heard me share that word for anyone that may not be familiar. So postvention are the opportunities that we create when a community has been impacted by suicide. Here are some things that we can do together, both behavioral health and faith communities, and certainly faith communities can come together. And I shared earlier about that bridge, and so here's a picture of the bridge that we want to create. And if you notice, most bridges have at least two lanes, some have four, and they go in both directions. And so the big idea, again, is that we create this bridge where people can go coming from a faith community to behavioral health to the faith community. So there's constant movement between the two communities, between the two opportunities, and we're constantly going over the troubled waters together, right? We're moving together, back and forth, working together over these troubled waters. And we certainly understand with suicide being, I think the last statistic I saw, suicide was the second leading cause of death. So we know that this is a huge issue, and we have to this should not be a one-time conversation. So I'm hoping that as we talk about building this bridge, going back and forth, that this is not your one-time conversation for 2022, but it's an ongoing conversation because it's the second leading cause of death for young people. And I call it young people because I'm 50, so anybody in their 30s is young to me. But from ages 10 to 34, it's the second leading cause of death in our country. And that's huge. And again, we just have to continue this conversation. So the goal is that these conversations, these issues, we don't just work together this one time, but we work together ongoing throughout the year. So we're prepared, we're ready, our communities are prepared, are set up to respond when impacted. So that's where postvention comes in. It is, what do we do when our communities, when our congregations, when our families are impacted? And we don't want to be found scrambling if we can avoid that. We know that, in life hits us sometimes and we don't know what to do. But when we can have a plan in place or have some ideas and have conversation and create connection, then we are better and more effective at responding. And because of the sensitivity around suicide, as community and congregations, we want to be fully as much as possible prepared to respond and prepared to give aid and help and resources and safety and security for those who are impacted. So here are a couple ideas around postvention. Again, co-hosting prayer vigils and or community roundtables. This is where, for those that may not be familiar, is where the community comes together. Oftentimes candles are lit. Oftentimes there is a word given. There is a word of hope shared by the faith community. This is often sometimes a space where family members can come to share. It is separate from, funerals and things like that. This is really where prayer vigils are really where community comes out. And oftentimes with prayer vigils, individuals come who don't really know the person, but they are impacted by the story. They're impacted that this happens so close to home or so close in their community. And so this is an opportunity where people can come to really, as a community, rebuild and begin to heal together. And this is part of that holistic approach. So we want to encourage with our behavioral health workers is to connect with faith communities in co-hosting prayer vigils, because also at these prayer vigils, what I have seen happen and what can happen is there can be someone in place from an agency that, as the community is doing what the community would do around candles and words and affirmations and prayer and, sermons and things like that going forward, there could also be information being shared so that others who are greatly impacted may not go down the same pathway, or that they may get the help that they need. This can also happen at community roundtables, co-hosting together. So we really want to encourage looking at working together on these prayer vigils. And these prayer vigils can happen with congregations, but also beyond congregational spaces. You can do prayer vigils at local schools. We just said that this is the second leading cause of death for individuals between the ages of 10 and 34. So certainly a local school, God forbid, a student takes their life, doing a prayer vigil, hosting a prayer vigil or a community roundtable at the local school. So we want to encourage seeing beyond where these can happen. And this is also for our faith leaders, that if there's a school in your community where you're worshiping, at the local school would be a good place to host a prayer vigil, because you get to meet people where they are. Local parks and recreation, of course, possibly where a student or an individual frequented, but also tapping in with sports and activity associations who also are known for bringing people together. So again, we're talking about postvention and working together to offer support to a community that's been impacted by suicide. These kind of co-hosting community prayer vigils, roundtables within congregational spaces, but also outside of congregational spaces. Joanne says, trust. People are already vulnerable and will not open for discussion. Yes. Need assurance of confidentiality and trust. How long does it, on an average, take to build trust, confidence in our work, so people feel comfortable engaging in our services? You know what, Joanne, that's a great question. So one of the things that we have experienced here at the Murray Center in the work that we do working with congregational spaces, we actually average, and this is not exact, and I don't know if there's an exact science to this, but what we've experienced, it takes at least 7 what we call touches to build trust in a community. So 7 touches could be 7 phone calls, 7 meetings, a combination of things. And so part of why it's important, it's a great question, Joanne. Part of why it's important that we're having this conversation now is so as community and even behavioral health workers, we can begin to touch the community now, right? So we're touching the community by having prevention awareness seminars, prevention community events, where space is given, holding hope forums, having very forward conversations where clergy are even speaking to the issue of suicide, using whatever sacred text is familiar to them, right? Because we have averaged, and it's a great question again, that it takes about 7 touches to create trust within a community. So again, to our behavioral health service workers, that's just an idea that you may have to connect with the church 7 times before trust is created, but also to our faith leaders. If our communities do not see us leading in these conversations more than 1 time a year, they also may not trust us. So we have to become trustworthy, right? That in the event they have this experience, they know that their pastor, they're your mom, their priest, whatever, or just their church community or worship community is engaging in this conversation on a consistent basis, and that that trust is built. But the number that we come to is 7, and there may be others who have a different input on that, and I welcome it. Again, it's not exhaustive, but we did experience it takes about 7 touches, and a touch again can be communal, it could be individual, it could be a number of different ways. So if you're thinking as a faith leader, and I see the question, if you think as a faith leader, a way to think about this going forward is, what are 7 ways throughout the year I can lift this issue and or other issues, right? What are 7 ways we can do this? If you're a behavioral health worker, what are 7 ways we can connect with the church that's local or the congregations that are local to us, right? And again, that number 7 is just something that we have come to figure out, but it's not exact. Maria says, one big barrier I've experienced is a lack of services offered in other languages, leaving some communities left out and alone to seek for their support that they need. You know what, Maria, that is so true. And even for us at the Murray Center, we recently did a session in complete Spanish because we recognize that, the Field to Heal room, breakout room, will go down in just a moment. Okay, thank you for that. One of the things that we experienced, Maria, is we were leaving out our Latinx brothers and sisters in some of our trainings that we were doing. So what we encourage, of course, is for faith communities as well as behavioral health service workers. Now, think about your materials, that they would be translated. One of the things that's really great about technology now, even when we talk about Zoom, like Zoom rooms, Zoom calls can even have translators on them. There are Google Translator. So there are a lot of apps available. Technology is so amazing. So to your point, Maria, there really isn't an excuse for us not to translate our materials into other languages. So again, if you're a behavioral health worker and you're embedded in a community, part of knowing the culture of that community is knowing the language and making sure that materials are translated. And I think for our larger organizations, they know that. But sometimes our smaller organizations may not have the resources to do that. But one of the things that I think is important to lift up when we're talking about barriers is that there are a number of free resources around language translation, as well as for our faith leaders that are on. If we're hosting public events, making sure that our flyers are both English and Spanish or English and wherever community you're embedded in, doing the best to translate that. But thank you, Maria. That's a huge barrier. And when people feel that someone can't communicate with them or they can't communicate, they may not go for services or may not go for assistance. And so we have to do our part, both faith communities and behavioral health specialists, making sure that wherever we're embedded, that we're also looking at language, because language is a huge barrier. So thank you, Maria, for bringing that up. So as we return to postvention, so we talked about co-hosting prayer vigils and community roundtables. The second piece is faith communities and behavioral services, bringing people together, family and friends of suicide victims that may be at increased risk of suicide and suicidal ideation themselves. And so again, this is why postvention is so important, because you may have an experience where someone commits suicide, but now others are impacted and they may be thinking or maybe considering that this is, might repeat the behavior and be so despondent by what they've experienced. We don't want anybody to be at risk of also committing suicide or experiencing suicidal ideation. So some of the things that we can do together is continue to educate, talk about corporate healing, look at corporate healing, and corporate healing is when communities come together. Community building is when we work on that bridge, and then we build something together. Build something together, meaning the behavioral health specialists and faith communities, what can we do together? What can we build together that meets the needs of families as well as families of those and friends of those of a suicide victim? How can we educate? How can we corporately, meaning come together to provide healing? How can we build the community? And we talk about, when we say community building, we're not talking about building a thing. We're really talking about building up people. How do we strengthen the community? And then how do we build something together? How do we create something, a hope forum, a community roundtable that creates space for friends and family members of a suicide victim to come and be a part of. So these are just some postvention activities and things to think about as we're looking at suicide. Again, suicide is the number 2, the second leading cause of death for ages 10 through 34. And one of the things that we also had in our conversation today is about overdose, because what we're seeing more and more, and I didn't put it in a slide, but I do want to just address it briefly, with the rise of use of opioids. And then I know there was a huge case recently in DC where we're seeing drugs now being laced with fentanyl. And so I know here in Los Angeles, we're seeing a huge spike in young people who are using recreational drugs, but they're overdosing because those recreational drugs are laced with things like fentanyl and other highly addictive, highly fatal drugs, synthetic drugs that are killing people in an instant. And they're also creating what we're learning is they're also creating deep psychological impact where people are having what I've heard is psychotic breaks, and they're not really returning. So I just wanted to kind of lift that up because part of this conversation is around overdosing, but we're seeing a spike in that in the last couple of years. And so again, this is something that faith communities should be aware of and be educating on, and also working with your local behavioral science workers and agencies to bring about healing and corporate healing, building community, talking about building people, but also building something together. So let's go to our next slide, please. Thank you. Faith communities and behavioral health workers, behavioral health services to work with. We want to invite you to host one-to-one conversations with leadership. So for our behavioral health service workers and our faith community leaders, as you are building this connection with each other, host one-to-one conversations before there is a crisis or before there is a need for radical services. So that way the relationships are already in place and existing, and then everyone can move on that bridge smoothly. And then also identify opportunities for education, opportunities for prevention, and opportunities for postvention. Really be intentional to look for opportunities for education, prevention, and then postvention. And then the last powerful next step you can take is to go to the care asset map. If you're not already a part of that, that map, you can use the map to locate behavioral health service workers or agencies. You can also use that to put yourself on the map. And the same goes for our faith community. You can use the map to locate, but also you can add yourself to the map. So Ruth has put the link in the chat for us. And so that is there. And we encourage you to go to the map, include yourself in the map, but also you can use the map to look for other agencies and faith communities to work with. So those are our 4 next steps: identify a community to work with and or behavioral service agency, host one-to-one conversation with leadership, and then really begin to identify opportunities for education, prevention, and postvention. But your homework is to use the SMART framework, identifying a goal for crisis care system improvements in your area, and then using the framework as a tool so you can begin to build your bridge. Every faith community, as well as our behavioral health service workers, should start thinking about building your bridge. And so we've provided this SMART framework tool that you can use going forward. So please make sure you click on that link. You'll also get it in your email, use it, and really start building your own bridge. Thank you for joining us today.
Thank you for attending. Thank you for taking time out of your day to join us and to share your feedback and to hold space with us. And these are all the different ways that you can keep in touch with the CARE TA Center. If you're not already signed up, we have a newsletter. You can follow us through social media, or you can reach out. Our information is there if you have any general questions. And so we just want to thank everyone for joining us today. And thank you so much, Rev. Najuma, for your time, your expertise in bringing this information to us and our community. And we'll see you next time.
Thank you.
Thanks, everyone.